But here, the submitral orifice, you can see that this is the orifice for the mitral valve, and the submitral fusion is so severe. And in such a patient, when you are doing the balloon dilatation, you may rupture the chordae and get into the MR. And that's why you can see that the submitral fusion is so much important. The thickening is there, submitral fusion, and especially when you insert the balloon, you can see that the distal portion gets deformed, and that is because it is caught in the chordae. For this, what we do is we put the peripheral balloon, dilate first the papillary muscle and submitral structures, and then do the balloon dilatation. Otherwise, you land in trouble. So here, the submitral structures are not mentioned in the report given, and it is said mild mitral regurgitation. So how do you calculate the mild mitral regurgitation? When the vena contracta is less than 3 millimeter, it is mild. Between 3 to 6 or 7, it is moderate. More than 7, it is severe. But what is important is, if there is an eccentric jet and then there is a reflux into the pulmonary veins, it is a severe. Though vena contracta or the eyeballing is not correct, that is very important. So when there is a combination of MS with AR, as in our case, this is the most common one. Only 10% of them have severe AR. Most of them, they have mild. And that's how we know when there is a mild AR, we can still do the balloon dilatation, provided that not much of calcification. If increased LVDP decreases the mitral stenosis gradient, and if both are severe, then we are underestimating both. So clinical findings, severe MS may mask the wide pulse pressure, and then AR murmur versus Graham steel murmur should be distinguished. But here the pH is 75, there is no PR on the echo, and hence we are not bothered about the clinical distinguishing. So whenever there is aortic insufficiency, it precludes the accurate measurement of the pressure half time. You can see that there are two jets. One jet is the candle flame appearance of the mitral stenosis, and other jet is the AR jet. So when two jets are coming on the echo assessment, we have to be very careful. Otherwise, if your cursor comes on the AR jet, you will be overestimating. And that's how you should be very careful when your cursor is put on the jets. Whenever we consider AR in MS, widening of the pulse pressure and apical impulse becomes hyperdynamic instead of the tapping apical impulse. And that's how it is very important. Now coming to the assessment of the aortic regurgitation, the LV dimensions are taken. In mitral stenosis, LV dimensions are less because it is underfilled. But when there is associated AR, LV dimensions are increased. So here AR on the left ventricle effect is seen. And apart from that, when you do the M mode, I showed you the M complex or the EF slope is reduced. But in presence of AR, you can see that there is a fluttering of the AML, and this fluttering of the AML indicates that AR jet is hitting the anterior mitral leaflet, and that's why it is fluttering. That means it is significant. So this is how you have to decide the AR. And the pressure half time is very important for assessing the aortic regurgitation. Apart from the deceleration slope, what is important is they can also have the vena contracta has to be taken. According to the vena contracta, grading has to be done. And most important is diastolic flow reversal in descending aorta is very important. Holodiastolic flow reversal in abnormal aorta is 100% sensitive and 97% specific for the aortic regurgitation. And hence in all the cases, whenever you are assessing the AR, you must look for the abdominal as well as the thoracic aortic flow reversal. And this flow reversal in the M mode, when you look at it, if there is a holodiastolic flow reversal, that means it is a severe aortic regurgitation. So here it is grade 1 to 2, that is mild to moderate AR is mentioned, and mild to moderate AR, that means still balloon dilatation for mitral stenosis is not a absolute contraindication. Still it can be done, but provided the mitral stenosis balloon dilatation is not possible in this patient, and then we have to assess the aortic valve also, because the surgeon can do the aortic valve repair also. And here, apart from the vena contracta, we have to look at the width, that is the ratio of the LVOT as well as the width, and that also has to be taken to decide about the aortic regurgitation severity. And apart from that, the tricuspid regurgitation is very important in this patient, because whenever we do the left-sided intervention, whether surgical or non-surgical, if the tricuspid valve is involved, the outcome is very bad. And that's how we have to assess the tricuspid valve, whether there is associated tears, organic thickening, beaded appearance, and whether the TR is functional, the secondary to the pulmonary hypertension. So, vena contracta less than 5 is still procedure is important. If the vena contracta is more than 7, and then the aortic valve repair or the replacement also are important. Now when you compare, this is a 24 years old lady, she is going to get married and have children, so we have to think of her future. So here heart valve replacement needs anticoagulation, which is like almost a contraindication. When she conceives, there can be anticoagulation complications will be there, whereas the heart valve repair, no anticoagulation is required, and the shorter time before reoperation. And that's how we have to think of the non-surgical options, and especially non-valve replacement. So according to the European Society of Cardiology guidelines, surgery should be considered in asymptomatic patient with preserved LV function and new onset of atrial fibrillation. But here we are not thinking of the surgical options. Surgical option is thought only if the LA dimension is very high. The huge giant left atrium is there. That happens when there is a MS-MR combination. And here you can see that the left atrium is going beyond the right atrium. This is a giant one. So there the